Welcome to section 23 of the Anatomy Online portion. We're going to be discussing the heart in this component. The heart is going to be a big topic, and there's going to be a lot of people that will be discussing different aspects of the heart. We're going to focus ourselves down to the physical attributes of the heart and the innervation, the really anatomical structures, and I'll leave the physiology and the pathology to those appropriate. Let's look at a question. A 52-year-old male with a 50-pack-a-year smoking history presents with a severe episode of hemoptysis. He's sent for a CT image of the chest, and a mass is detected anterior to the T8. The tumor is compressing the posterior border of the pericardium. If the tumor continues to extend, what other structure is like to be compressed by the lesion? And for this, we're looking at the left atrium. If this starts to push against the pericardium, the left atrium is in the position of the posterior component of the heart, and it will be compressed by the tumor. We'll look at further divisions of the various areas of the heart a little bit later. Now, if we look at the sternal angle, that vertebral level of T4, T5 we mentioned is going to be an important plane because it's the plane of Ludwig. And that's where the aortic arch begins and ends. The azygos vein will enter into the superior vena cava, oftentimes around that level, and it will basically be the root of all the great vessels. So what are some of the things that we can see right here? First, we can see the pulmonary trunk just prior to its dividing into the right and left pulmonary arteries. Then you can see it outlined here, and finally we can start to see some of the pulmonary veins distributed around it. Now we can see the ascending aorta. Here we can see the descending thoracic aorta, and the arch of the aorta would be coming up from this. So if we were to go up in this section, we'd see the arch and the major branches coming off the arch. Whereas if we were to go down in this section, we'll start to see chambers of the heart. Again, we can see a superior vena cava just off to the right and in the vertical plane, so it looks like a fairly good cross-sectional round structure as opposed to an oblong structure. And you can see the mainstem bronchi because there's going to be the bronchus bifurcating at the area of the carina. In fact, you can even see a little bit of the carina. Posterior to that, we can get a good look at the esophagus. In the question prior to this, we were a little bit lower than this particular section, and a tumor growing forward from that level would start to push on the atria, which will be lower down. Off to the side, on the right side, you can see the azygos vein, which is collecting the blood from the thorax and the thoracic wall. Now let's look at some of the external features of the heart. We have a base, an apex, a diaphragmatic surface, a sternocostal surface, and then we can get into the margins. On the left, there'll be an obtuse margin, which is more rounded than the acute margin, which is a little bit more narrowed and on the inferior border. The right margin is going to be formed by the superior vena cava and right atrium, and the left margin is largely formed by the left ventricle and a small portion of the left auricle. The coronary sulcus is in the atrioventricular groove, and it will separate the atria from the ventricles. The posterior margin is going to be made up from the left atrium, and that's going to sit against the esophagus, which can actually be compressed by anything that causes left heart hypertrophy. Let's look into a few of the features. We're not going to spend a lot of time naming all of these. They're labeled here, and I'd like you to take a look at those and make sure that you're familiar with all of the terms that we'll be using in the remainder of the heart segment. One thing I do want to draw to your attention is the moderator band, the papillary muscles, and the valves in the right atrium. One valve will be set up as an inferior vena caval valve, and I want you to notice the coronary sinus with a small valve there. Notice that this is going to set it up so that the blood coming through the inferior vena cava is going to shoot through the fossa ovale, which is particularly of importance in an embryo. It's also going to divert the IVC blood away from the drainage of the coronary sinus. Since if this is starting to get blocked and stopping the flow from the coronary sinus, you would get congestion, because if you can't get blood out, you of course can't get more blood in. We'll look at the borders of the heart here and the projections as it relates to the plain film here, and we'll start to add up the sides. So we can first see where the superior vena cava would be, along with the right atrium and the inferior vena cava. The right ventricle will form a major portion of the anterior heart and this diaphragmatic surface, and then you'll have the left ventricle that will form a major portion of the left surface of the heart. There's a small bump where the left auricle will project out, and then the pulmonary trunk and the aortic arch, which would be the aortic knob or knuckle. This is just an animation to remind you about the flow through the heart itself. Again, we'll move fairly quickly. It's going to come from the right atrium and then into the right ventricle. That ventricle will then contract and push it through the pulmonary trunk to the pulmonary arteries and into the lungs. It's deoxygenated at this point. It's going to be oxygenated in the lungs, coming back through the pulmonary veins, and now oxygenated into the left atrium, drops through the mitral valve into the left ventricle, and then is ejected from the left ventricle through the aortic semilunar valves and into the aorta to be distributed to the systemic body. The major branches off the arch of the aorta will distribute to the head and the upper limbs, and the descending thoracic aorta will descend and distribute to everything below that. And here it is in words if you are an auditory or visual person and would rather have it written down. Let's do a question. A 58-year-old patient undergoes angiography to evaluate his coronary arteries. The cardiologist notes that the patient has a left dominant heart. Which artery does the posterior interventricular artery arise directly from in this case? And you should be thinking of the circumflex. The circumflex vessel is going to be the second major branch off of the left coronary artery. The primary branch coming off of that would be the anterior interventricular. In a left dominant heart, as we'll see a little bit later, the posterior component of the heart is going to be supplied by the circumflex, which typically would end around the ventricular left side. But in this case it will be dominant and will carry around to the posterior interventricular artery. This is not as common as being right dominant. So we have a couple pictures here, one showing the ventricular contraction phase or systolic contraction, and this is going to have the semilunar valves opened. So the pulmonary semilunar valve and the aortic semilunar valves will be opened up during systole, and then the tricuspid and bicuspid will be closed. In the ventricular diastole component or relaxation phase, it will be reversed, where the semilunar valves will be closed as the aorta and pulmonary trunk elastic walls recoil and try to push blood back down into the ventricles. It's prevented through these semilunar valves closing up. That will fill the coronary vessels. There you can see the left coronary artery, and then the right coronary artery is going to be on the other side. And you can also see the names of the valves. The way that I remember the names of the valves is I think of a little person standing in the valves with their head towards the anterior side of the heart. The pulmonary trunk is going to have an anterior and a left and right upper limb, and the aortic valves are going to have a lower left limb and a right limb, and then there's going to be a penis, which would be the posterior. So if you have these vessels being fed with the semilunar valves closed, look at how the atrioventricular valves, the bicuspid and tricuspid, are now opened as the atria contract blood back into that ventricular space during the relaxation phase. And it's this sounds of these valves opening and closing in contrast to one another that gives you your heart sounds. The first sound is going to coincide with the closure of the atrioventricular valves at the start of systole, and the second sound is going to be produced by the closure of the aortic and pulmonary valves at the end of systole. Let's discuss the coronary arteries. There's going to be blood flow during the relaxation phase of the ventricles, which will then fill the ostia that are at the base of the left and right semilunar valve on the aortic valves. That blood flow will go through the coronary arteries and it's going to feed the myocardium. The right coronary artery and the left coronary artery and some variations in any arterial supply will determine dominance. Typically, right dominance is going to allow for the distribution of the posterior interventricular to be coming off the right coronary artery, whereas left dominance, as we saw in our earlier case question, is going to be distribution from the circumflex. There can be a balanced distribution which occurs when the coronary arteries are sharing this load, but when you have a left dominant heart, you're now putting more eggs in one basket, so to speak. So if you get a blockage of the left coronary vessel, you can have a more major effect from that. Angina pectoris is going to be a chest pain associated with myocardial ischemia, and it's usually going to be increased by increased demand. So as somebody is active, they're going to have significant tightness and pain in their chest wall as a referral as a result of the anoxic feeling of those visceral afferents that they're picking up from the heart muscle. And it can usually be subsided through taking sublingual nitroglycerin. Then the venous drainage of the heart is going to be important as well. There's going to be blood from the heart that has to get back into the heart, and it mostly returns to the right atrium through the cardiac veins. The largest of the cardiac veins is going to be the coronary sinus, and we'd mentioned earlier that it runs in the atrioventricular sulcus. That's going to collect the venous flow back from the other major areas of the heart, and each major artery has an accompanying major vein. So the anterior interventricular artery has the great cardiac vein running behind it. The posterior interventricular artery has the middle cardiac vein alongside, and the small cardiac vein has the acute marginal right artery running along the right marginal surface. There's a posterior vein which will come off the left ventricle, and it will drain the diaphragmatic surface. And then there's an oblique vein which was going to come off of the left atrium and represents the embryonic remnant of the left sinus horn. And that persistent left horn in a cardinal vein is the basis of the left superior vena cava. The anterior cardinal vein is going to have a few of them, and they'll drain directly across the surface of the right ventricle and right into the right auricle. Then the small cardiac veins, also known as thespian veins, will arise off the walls of the heart and open directly into the chambers. Most of them are going into the right atrium, though, but they can drain directly back into the chamber. Here's a question. A 45-year-old man presents to the emergency department with a complaint of crushing chest pain. His labs reveal elevated cardiac enzymes suggesting an acute myocardial infarct. Echocardiograph confirms a kinetic segment of the left ventricular and interventricular septum. This akinetic segment is explained by one artery being obstructed. And which artery is the most likely? And that's going to be the anterior interventricular artery. Continue on and we'll see some of the reasoning behind this scenario and its answer. If we look at the conduction system of the heart, you can see that there's going to be two nodes, the sinoatrial node and the atrioventricular node. The SA node is going to initiate the heartbeat and be the pacemaker, and it lies at the edge of the right atrial wall near the superior end of the superior vena cava. The SA nodal artery is going to come off of the right coronary artery. And then a wave of contraction is going to spread over both atria, but it can't reach the ventricles because of the fibrous skeleton where all the vessels and hearts valves are located, because this is electrically inert. And the only spot where that conduction impulse can be passed on to the ventricles is at the AV node. And that AV node is going to lie at the interatrial septum near the coronary sinus in the right atrium. It's going to get impulses from the SA node that will pass through it to the left and right atrioventricular bundle. From the AV node, the artery is going to be coming off of the coronary artery, the right coronary artery. So both nodes get blood supply typically from the right coronary artery, and that can be a major problem with tachycardia and issues that will come from a result of a myocardial infarct that affects the right vessel. If the AV bundle ends in a plexus known as Purkinje fibers in the ventricular wall, then it's going to dissipate that force into the myocardial cells themselves. And there it's going to divide those bundles into the left and right bundle branches, which will then carry on to the moderator band. The moderator band is a muscle band that carries across from the atrioventricular septum over to the base of the anterior papillary muscle. And that anterior papillary muscle will then be one of the first areas to get this conductive wave of electrical impulse. The entire conducting system is really a specialized set of muscle cells that have lost some of their contractile components and added in hyperpolarizable membranes. And they get direct stimulation from the sympathetic as well as the parasympathetic cardiac branches. There'll be a collection of these specialized muscle cells which will feed into all of the cardiac muscle, and what it does is it starts a spiraling contraction from the apex of the heart all the way up to the fibrous skeleton again. Let's look at it in the next slide and see how this works in graphic form. We'll start with the SA node, which will get direct input from the autonomic system, and will send a depolarizing wave through the atria, which will then hit the fibrous skeleton, which is inert. The only spot that will allow that depolarizing wave to continue is those hyperpolarizable areas of the AV node. And the AV node will then divide into the left and right bundle branches of His, and that will carry on down in these specialized Purkinje fibers, and they'll start a contraction from the apex upwards, and since the muscle fibers are directed spirally, this contraction is also directed spirally. So here's the sequence of events in words for those of you that would prefer to look at it this way. So let's review a little bit about the autonomics of the heart. We know that there's sympathetic and parasympathetic inputs. The sympathetics will come off of the sympathetic chain from T1 to T4, and they'll tend to be postganglionic. The parasympathetics will come from the vagus nerve and will tend to be preganglionic. That means that we're going to need some ganglia diffusely distributed through the walls or near the heart and lungs and the viscera of the thorax. The sympathetics are going to supply vascular smooth muscle, and in the coronary vessels they're going to also have parasympathetics that have direct vascular influence along with these sympathetics. A couple clinical considerations would be heart catheterization and angiography. Here you can see a C-arm around the pretend patient, and you can see all of the major vessels of the coronary arteries. So therefore, for heart catheterization, depending on which side of the heart you want to go through, you can find out whether you're going to go through venous systems or arterial systems. If you wanted to get into the left heart, you can track back through the femoral artery and see the valves of the semilunar cusps associated with the aorta, and then get into the coronary vessels from there, dropping a dye into it and seeing all of the coronary arteries, just as you can see in the top graph. If you wanted to look at the right side of the heart, you can come through the venous system, either the cephalic, the median cubital, or the femoral vein, and track through either the superior vena cava or inferior vena cava, depending on which way you want to get into the heart. And you can drop dyes in to look at the right atria or even the right ventricle. And that's going to be a contrast study using a C-arm, which is typically going to give you a fluoroscopic view of what's happening, so you can in real time see the distribution of these materials through the heart. With an acute myocardial infarct, you're going to have a lot of testable material, most of which we'll talk about with the pathology, I'm sure. And here this just shows in cross-section some of the different views and how it'll look pathologically on post-mortem. Notice how an acute infarct has not scarred in like the one that is years old, and somewhere in between those two is the subacute, which would be a few days old. The rest of the myocardium is perfused and looking quite red. The symptoms of an acute myocardial infarct are going to include sudden chest pain. There's going to be a lot of anxiety associated with these, shortness of breath, crushing chest pain, sometimes nausea, vomiting, palpitations, and even sweating, because there's going to be an autonomic overshoot with some of this, and if there's tachycardia or anything like that. Women oftentimes will experience fewer of the typical symptoms than men, and if you look at the deaths as a result of cardiac myoinfarction, women who tend to have one will actually have a higher risk of dying from it, sometimes because of this educational difference that women, A, don't think they're supposed to get heart attacks, and B, don't recognize it as quickly because we've been educating them that they should have all of these things even though they may not. 1/4 of the infarcts are going to be silent without any kind of chest pain or other symptoms, and that's why you'll oftentimes see these old myocardial infarcts or these zones of inactivity in the heart, and somebody was not aware of it. And this can sometimes be because of collateral circulation sprouting through slow disease process. However, remember, these vessels of the heart are end arteries. If they die and they're not getting fed, something will not be getting oxygen and it will die. If the blockage of the coronary vessels happens over slow periods of time, though, they can oftentimes accommodate. Let's move on to the next slide and start looking at a couple other things that can happen around the heart. Here we can see aortic dissection. And we have an aortic dissection which is actually going to be a tear in the wall of the aorta, which will allow blood to flow between the layers or the lamina of the aorta and the adventitia. This is going to start putting hydrodissecting pressure not only in the adventitia, but it will start compressing, as can be seen in the bottom inset. It starts compressing the vascular lumen. When you compress the vascular lumen, every time you cut that diameter in half, you're going to quadruple the force requirement to push through it. And that, of course, can have some bad side effects for strokes, and all of the other associated things can happen from this. That dissection will be stale blood, which will start to actually push downwards or upwards from its initial point of tear, and can occlude even more of this aorta, and maybe even occlude major vessels as they would distribute to the body. Here's where some of the aortic aneurysms will oftentimes occur. They're either at the aortic root, or the ascending aorta is a common site, or even along the entire descending aorta. It's really a weakening of the portion where it's dilated, unlike the dissection, which gets in between the layers. This is going to be the internal wall actually pushing out. They're more frequent below the diaphragm in the abdomen, but here are the major portions where they occur within the thorax. If you have a traumatic aortic rupture, something we mentioned earlier where it can be torn at the arch where the ligamentum arteriosum attaches, this can result in shock and death in over 85% of the people that have an aortic rupture. Surviving one of these is pretty fortunate. This will happen in automotive accidents because the vessels of the heart are still going 60 when the front end of your car hits whatever it hits. And that means that that forward momentum of the mobile heart and that tethered ligamentum arteriosum can tear through into the aortic arch, and they can exsanguinate into their thoracic cavity. Aortic disruption is going to be a killer for about 18% of the deaths that occur in automobile collisions. And then there's going to be a large portion of these disruptions that are results of blunt chest trauma. It's only second to the leading cause of injury and death, which will be traumatic brain injury. Let's turn to another question. A patient walks into the ER complaining of breathlessness and a racing heart. While getting a history involving the facts that the man suffers from hypothyroidism, the nurse notices jugular distension and drowsiness in the patient. The patient loses consciousness suddenly, and the nurse quickly finds muffled heart sounds and has difficulty feeling a pulse, especially on inspiration. What is the most likely diagnosis? This one's getting a little tougher, but hopefully your red flags were going off when you saw that there was jugular distension. This could lead you to tension pneumothorax, or the answer, which would be A, cardiac tamponade. Now, this one's tougher because there's a couple different ways that you can have cardiac tamponade. One way is through chest wound or injury to the pericardium or the heart itself, which will bleed into the space, or in this case the hypothyroidism, which is a slow onset as a result of the hypothyroidism. And this is going to distend the pericardium because of fluid accumulations in there, and they can actually have quite a lot of blood in this space, whereas a typical traumatic tamponade will only require a couple hundred mils of fluid to create the pressure that would lead to death. Let's look at the pericardium and the layers of the pericardium. We know there are two portions to the pericardium, a fibrous and a serous pericardium, and the serous pericardium is going to have two components to it. There's the visceral pericardium right against the heart, and there's the parietal pericardium, which is against the inner wall of the fibrous pericardium. This is a typical serous sac, which will have small amounts of fluid so that the heart can beat within its pericardial sac, and the pericardium itself will protect the heart and give it something to push against so it doesn't waste energy in bulging. Remember, the phrenic nerve is going to be embedded down the side of this pericardium, and the phrenic nerve goes in front of the hilum, whereas the vagus nerve will go behind the hilum. That's an important relationship because tumors in one area of the hilum of the lung versus the other may have differential pressures that it will apply basing on whether it's going forward or backward. And the phrenic nerve is going to be innervated by C3, 4, and 5 nerve roots. Here we have a penetrating trauma. This is automatically something that you're going to think of a cardiac tamponade, until proven otherwise, actually. If you have a penetrating chest wound like this one, where somebody's car antenna or radio antenna had been punctured through into their chest, you can see that this could have a damage to the heart. And in fact, in this case, it did. You must assume that there's cardiac damage until proven otherwise. Kind of things are you going to see if there's cardiac damage? Well, the cardiac tamponade signs will come up. In the acute cardiac tamponade like this one, it can take only 1 or 200 mils to completely occlude the ability for the heart to pump. In that slow onset hypothyroidism, it can get anywhere from 500 or even a liter of tissue because it will be slowly dilated from the accumulation of serous fluids within the pericardial sac, not vascular fluids like blood. And you're going to have the Beck's triad of symptoms, which is going to be hypotension, jugular distension, and muffled heart sounds. Those three things should be red flags when you're looking at the study of cardiac tamponade. This is a graphic of the cardiac tamponade, and for the drainage of this, they'll tend to go to the left and medial side around the 6th intercostal space, and they'll come upwards. And what this is going to do is going to be able to drain the fluid from the pericardium, allowing the heart to beat again so that they can begin in there and surgically treat the reason for the bleeding. Here you can see a mortal cardiac tamponade in this great big clot that burst out when the cardiac sac was opened. So the pressure buildup that happens as a result of the cardiac tamponade does exactly what you'd expect. It's going to compress the venous system, which reduces the filling of the heart into the right side. That's going to give you your jugular distension and cyanosis, because if you can't get blood into the heart, you won't be able to get blood out of the heart. You're going to increase the workload on the left ventricular system, which will lead to failure. That will lead to pain and palpitations as well. That imminent death anxiety is what people will oftentimes resort to, and because they have that feeling, they'll be very agitated and seem restless. That concludes our section on the heart. The next component we'll look at is some of the developmental features of the heart.